punch it in, and then you come up with a result of what are the odds that if we did a biopsy, we would find cancer. And there's some more variables that are, more of these tables are coming out that seem to be helpful in making a decision about the biopsy. What's really new and exciting, and I think we're going to hear a lot in May, the American Urology Association national meeting's occurring, and I think there's going to be a lot of press about new molecular markers that are coming out that will, one, potentially identify men who really need a biopsy versus men who don't, try to eliminate those false positive PSAs and do less biopsies. And then if we do find a cancer on a biopsy, have a better understanding of whether this cancer is high risk, low risk, or intermediate, and whether they need treatment. So you can look this up, COGS, Collaborative Oncology Gene Environment. There was just 15 articles published last month about this. An amazing study, 160 centers across the world, looking at a variety of cancers, not just prostate. They found specifically with prostate 23 new markers, and I think some of those will end up going to market as some test that potentially will identify an aggressive tumor. And that'll be very helpful in helping us make our decisions about treatment. So that already hit the New York Times, and this may again be our saving grace to figure out whether we should be screening. It would be better to have a better screening test. Huge cost to treatment, and maybe these tests will help, in some respect, lower the cost if we can prevent some treatment that's being done unnecessarily. Let's move on to biopsy. So we're using an ultrasound transrectally to guide a needle into the tissue, use a local anesthetic to numb the prostate, numb the rectum up, 20-minute procedure. It can still be uncomfortable. Some men have some discomfort. Some men don't notice a thing. I know there's somebody here in the audience who just had one today, and I think he's still here sitting. Need antibiotics before it to prevent a urine infection or sepsis. You need to be off blood thinners. You will see some blood in the urine and some blood in the semen for a time, but that'll go away. There's less than 1% chance of significant bleeding, but it does happen. Here's some images of the transrectal ultrasound, biopsying the prostate. So what are the risks with the biopsy? Well, I've talked a little bit about that. Again, this false positive, that is, and false negative results. False positive, you've gone through a biopsy and there's no cancer, and you've just gone through a procedure. The false negative results, there's no cancer on the biopsy, but in fact the PSA remains elevated, and we end up with this quandary of do we have to do another biopsy? And it's possible if there's a 25 or 30% chance of finding cancer on the first biopsy in men who have been studied with persistently elevated PSAs. If we go back and biopsy a second time, there's probably a 10% chance of finding cancer on a second biopsy. In the last few years, we've seen a rise in the number of infections after prostate biopsy, and it's been a real difficult situation. And essentially, it's because the bacteria out there in the community are becoming resistant to the old standard antibiotics that we used for biopsies. So now, with a new protocol of using multiple antibiotics, we've reduced the infection rate down again to about 1%. So that's a sample of the cores that we get. These are actually the pieces of prostate tissue that then get sent to the lab to be analyzed by the pathologist to look for cancer. That's actually a prostate that's been removed after a radical prostatectomy. And if I have a little laser pointer so you can see here, this would be the urethral opening, the connection to the bladder. You could imagine the bladder sitting here, and here's the seminal vesicles. This would be where the urine would exit out through the penis. And I represented these, I don't know if you can see these little black lines, but these would be the standard 12-core biopsy that we do now. And you can see we're sampling, mapping out the prostate. There's obviously still, based on the size of the prostate, a potential to miss a small tumor in between those cores, and that's how you might get a false negative reading on a biopsy. This is the Gleason score. Gleason was a pathologist 35 years ago that looked at the way the tumor looked under the microscope and graded it, and you can see the grades here. Down below, that's kind of what normal prostate tissue would look like. And the higher the grade, the wilder the tumor looks. It's no longer producing the ducts, the canals that a normal prostate would have. And so the higher grades are more aggressive and more likely to spread. So here's a new topic that we're going to be, I'm sure, mulling over in the urology arena as to whether Gleason score 6, so Gleason, that's the lowest number you can get on a biopsy. Gleason score 6 would be a well-differentiated, low-grade tumor. Should we be calling it a tumor? I think we're going to continue to call it a tumor, but we really want to look at it in a different light. I'm just going to read this quote. The extent to which overtreatment is caused by fear of death resulting from cancer, fear of litigation from undertreatment, and misaligned incentives that reimburse us more for treating rather than monitoring when appropriate is not known. But this is the issue we're dealing with as urologists. And the proposal would be, this Gleason 6, we're going to put it into a different category and recognize that if you've got minimal cancer on the biopsy and low grade, your chances of dying of prostate cancer is quite low. Got a higher grade tumor, we're going to want to treat those tumors. But the lower grade tumors, we really want to make a conscious effort to recognize what we're getting ourselves into, and maybe surveillance, which I'm going to talk about shortly, is a good idea. Should I be screened? Depends on your individual risk factors. Hopefully now you can make a decision about screening for prostate cancer with a PSA and digital rectal exam. I'm going to take a short break for questions because we're going to move on to the next topic, which is going to be treatment for prostate cancer. Does anybody here have any questions about the PSA test or screening?
How does BPH factor in?
So benign prostatic hyperplasia, as men age, there's even a higher risk of developing BPH as opposed to prostate cancer. And the larger the prostate, the more PSA it makes. Now, the PSA still has to leak out of the prostate into the bloodstream. And so it's interesting how some men will have very large prostates and a very normal PSA. But a large prostate is going to predispose you to having an elevated PSA. And so that's one of the major reasons for a false positive PSA is you don't have cancer, you just have an enlarged prostate. Good question.
If you have BPH, do you not have cancer then?
No, you can have both. You can have both. Yes, sir.
Is there an age-related family risk? So in other words, like my father was diagnosed with prostate cancer at 78. Does that put me at an elevated risk, or is there sort of an age level?
So we think that the bigger risk for men is a relative who's had prostate cancer before the age of 65. If you've got a relative who got prostate cancer at 78 or 88, it's just it's a more common variety of prostate cancer. We're thinking that the genetic predisposition of prostate cancer is also probably getting men at an earlier age. So it's a higher risk when your relative is younger.
I generally have a total PSA when I test
Yeah.
and do that. Is there any advantage to having the bound versus free?
So the percent free PSA, like the PSA velocity, these are other ways to look at PSA as a marker for prostate cancer. So the lower the percent free PSA, the higher the risk that the elevation in PSA is due to cancer. And it's somewhat helpful. There's some controversy as to really how much better detection of prostate cancer it is compared to a standard PSA. I think what we'll do is keep going, and then at the end of the next section, we'll open it up for more questions. So the next topic, deciding on treatment for prostate cancer. What are we going to do once we do find prostate cancer? The main thing is that you need to know that you do have options. It's your decision, and you really need to get informed about the options. So you talk to your doctor, get second opinions. It's helpful, I find, to talk to friends and other patients, but you've got to realize every individual and every cancer, it's an individual situation, and what some guy swears is the best way to go is not necessarily the best way to go for you. But it makes sense to talk to other people. I'm going to focus now on active surveillance as one form of treatment and surgery. I'm a surgeon. Radiation is another good option. We've got a great radiation program here at Cottage Hospital that deserves a whole nother lecture in and of itself. Cryotherapy, another form of treatment I use often for men to freeze the prostate. And there's various reasons to use one treatment or another, but we're going to focus on active surveillance and surgery tonight. What is active surveillance? It's monitoring men closely who we know have prostate cancer, and hopefully it's localized, so we've got to choose very carefully, but we think there may be 20% of men out there with prostate cancer that may be candidates for active surveillance. That means low-risk cancer that may end up getting treated down the line. So some people say it's just delayed treatment, and that's the issue we've got to try to resolve. And the idea is that we're going to try to safely observe and still maintain that window of opportunity of curing cancer if it needs to be cured. So the advantages, really good choice for the guy, and we call this more watchful waiting, for a guy who's got other health issues and not likely statistically to be around in 10 years. Many prostate cancers don't need to be treated. On the other side, again, if we identify a slow-growing prostate. The advantage, really no, you're not in the hospital, you don't need any surgery. Yeah, we've got to do some treatments in the office. Problem, we may miss a chance to treat cancer before it spreads outside the prostate. But you're avoiding the possible side effects of treatment. It's the advantage of active surveillance. As you get older, things may also change with your health, and you may not be able to tolerate treatment down the line. In the future, we may come up with some other ways of managing prostate cancer. It'd be nice to be able to hold off. Problem is, many cancers that we initially diagnose on the biopsy as being low grade actually end up being higher grade, and we know that through the surgeries. And I'll show you an example in the future. We often think we have a Gleason 6, a low-grade tumor, and it turns out it's really a high-grade tumor. And that can get out of control. Are you suitable for surveillance? Is your cancer suitable for surveillance? And the common entry criteria would be a low Gleason score, a 6, no pattern 4 or 5, a low PSA. The number of biopsies, and our standard now is typically 12 cores, 12 different samples. So we want to see just a few, at most, cores with cancer, and those cores should be low volume cancer, so a small amount of tumor on the biopsy. Then the question is, are you personally suited for surveillance? Could you live with the idea that you've got cancer in your body without having anxiety? And I think that's what we really need to work on for many people, is understanding that, yeah, we call it cancer, but it's like potentially a little skin cancer, and it, isn't necessarily going to create a problem. Can you live with that idea? Are you more concerned about the side effects of treatment versus the actual cancer? And it's the quality of life issue, and you've got to weigh that decision, and again, understand that you're potentially risking that window of opportunity to treat a tumor. So how's it done? There's a variety of protocols, but essentially it's repeating PSAs on a regular, more frequent basis, actually, and repeating biopsies. And that means potentially if there's a question on the first biopsy of what the grade is or what the volume is, maybe doing a biopsy a few months later. And then once we're sure there's really low grade, low volume tumor, following PSAs and probably doing a biopsy at 12 months or 18 months down the road, and then basing our biopsy decision on what the PSA is doing and what the digital rectal exam is doing. But it probably means more biopsies. Again, complications, I think we've talked about that, and the complications of repeated biopsies, and that potential of missing an opportunity to cure the tumor. So what actually happens? This is one study from Johns Hopkins. When they had men under surveillance, 30% of them end up after 40 months moving on because of those same issues. Either they're afraid or maybe their doctor's afraid of watching. There's a sudden rise in the PSA. The repeat biopsies show a higher grade or a higher volume of tumor. Those are indications to treat. But after 7 years of surveillance, there was no death from prostate cancer, at least in their study. High-grade tumors, consistently about 4% a year were developing. So the Gleason 7s, 8s, or 9s were being found in the surveillance group. A small but persistent percent. And this is their estimate. This isn't a study actuarially over time, but they're estimating that for a man who's 65 who enters a study like this, your chance of, with low-grade, low-volume tumor, of dying of prostate cancer at 20 years is 5%. And there's a higher rate of dying of other intervening diseases in the interim. Okay, so we're going to focus on surgery now. Goals of radical prostatectomy. That's the surgery to remove your prostate, remove the seminal vesicle gland. The goal is to get the cancer out, to remove the tumor while it's confined to the prostate. And for good or bad with surgery, we're going to know, pathologist is going to be able to tell me a week later, is that cancer confined to the prostate? Or has it spread through the capsule of the prostate? Is it somewhere else? Also with surgery, we want to be able to preserve the urinary function, erectile function. We don't want to have side effects. Again, with surgery, we like to think that this is the best, if we're going to treat prostate cancer, this is the best way to treat prostate cancer. And there's a lot of studies out there suggesting that the long-term results, 10 years, 15, 20 years, prostate cancer has a better outcome than any other form of treatment. Brief history, I just looking up this talk, didn't realize the first prostatectomy is thought to have occurred in 600 BC. Hard to believe. More modern times, Dr. Millen, who was in London, did the first, what was considered the first radical retropubic prostatectomy in 45. One of his proteges came to USC, and actually the first radical prostatectomy in the United States was done at USC. Not soon after, probably in the late 40s. More recently, the big change was Patrick Walsh at Johns Hopkins, who did a lot of anatomy studies, figured out why we were losing the blood that we were when we were doing surgery, and figured out how to tie the blood vessels properly to lower our blood loss during surgery. And then he did some more studies to look at the neurovascular bundle, the nerves that innervate the penis that go along the side of the prostate. And by identifying where they were, he came up with a plan on how to do a surgery that would spare the nerves, preserve the nerves. And that's increased our ability to maintain erections after having had the surgery. For years, in my training, it was an open incision through the belly. Then in the 90s, laparoscopy started to occur. We were using it for other types of surgeries. Laparoscopy means putting little holes in the belly, filling the belly with gas, and then operating to remove the prostate. Schuessler attempted it in 92. I think it was a 9 or a 10-hour operation. Eventually did some cases that worked. Still a long operation, complicated operation. And it was abandoned for a time. And then in 98, Guinaud in France came up with a good, repeatable technique to do this laparoscopically, and that became a popular way to treat prostate cancer, laparoscopically. The first robot prostatectomy was done in 2000. I did the first robotic prostatectomy at Cottage in 2005. So again, the difference between an incision and the puncture holes, the thought is, instead of making that incision, making little puncture holes, people will recover faster. Here's a picture of our first surgery. I got Dr. Kawachi from City of Hope to come up to help me with my first case. We did 8 or 9 laparoscopic prostatectomies in 2002, 2003. And I bring this picture up because you can see I've got my arms up and my neck tilted, and I can tell you after hours in the operating room, I'd come home and I'd be pretty sore. It was a very physically demanding procedure. So my path through to the DaVinci prostatectomy, the robot, again, prior to 2005, I was doing retropubic or open prostatectomies, over 160 of them. A lot of training went into this. Computer Motion was a company here in Goleta that actually had the ESOP, a robot that you would talk to, and that would help move the camera. We did surgeries out there on cadavers. We did surgery at USC, City of Hope, a lot of seminars, Ohio State. We had a pig lab at Cottage Hospital. We had some down at USC. We did cadaver surgeries, operating on prostates that weren't bleeding. And then slow progress after learning how to do laparoscopic surgery for kidneys. Then we went on to laparoscopic prostate surgery and then used the robot for the prostate. Now we're using the robot to do kidney surgery, especially partial nephrectomies. We had an extensive training program here. I had mentors. I had 10 proctored surgeries before I went on to do my own surgeries. And since that time, We've done over 400 cases. There's 3 surgeons here at Cottage, Dr. Curhan, Dr. Coper, and myself, that are doing robotic prostatectomies that have been certified to do that. We've got